Hi, everyone. I'm Leslie Lappalainen. I am a family physician and addiction specialist. I work in Kelowna at Kelowna General Hospital as an addictions consultant there. And it's a pleasure to meet with you all today to talk about strategies for induction for buprenorphine naloxone. And I just want to thank the BCCSU medical writing team for putting these slides together today. So we have a fairly ambitious agenda today to cover the following learning objectives. So I'm going to try to get through all the slides in the next 20 minutes or so. By the end of the session, I'm hoping that you will be able to describe the pharmacodynamics and pharmacokinetics of buprenorphine naloxone. We'll talk about using the clinical opiate withdrawal scale and the subjective opiate withdrawal scale, so the COWS and SOWS respectively, to assess opiate withdrawal. And then we'll describe low dose inductions as well as traditional inductions and how to do each of these induction approaches and how to kind of decide when a low dose induction might be most appropriate versus a traditional induction. And just a note that the low dose induction is the same thing as a micro induction. The terminology in the literature is kind of shifting towards the term low dose induction, but the two terms micro induction and low dose induction mean the same thing. So first, just an overview of buprenorphine naloxone. As most of you will know, it's a first-line oral opiate agonist therapy option and is considered first-line because of its safety profile as a partial opiate agonist. So we'll talk in the next several slides what that means. All forms of oral OAT are superior to withdrawal management alone in terms of retention in treatment, sustained abstinence from opiate use, and also decreasing overall morbidity and mortality. And just as kind of a reminder, withdrawal management alone, like having someone go to a detox unit alone without putting them on OAT, is not recommended. Individuals can lose their tolerance to opiates really quickly. And if we don't put them on OAT, the risk of relapse to kind of illicit opiate use remains upwards of 90%, but we've taken away their tolerance, so they're at an increased risk of death. So withdrawal management alone is not recommended. In terms of what buprenorphine naloxone is, I'm going to try my hardest throughout the presentation to say buprenorphine naloxone, not Suboxone. So Suboxone is a brand name, but essentially it's a tablet that contains buprenorphine and naloxone in a 4:1 ratio, and it's taken sublingually, so it's dissolved under the tongue. In BC and in Canada, it comes in 2 milligram tablets and 8 milligram tablets. And again, it's given sublingually. So we usually counsel patients that in that, when they're taking the medication, takes about kind of 5 to 10 minutes for the medication to dissolve. And we tell them kind of no eating, talking, drinking. It is dissolved kind of in the small blood vessels under the tongue and in their cheeks. So try not to swallow your saliva in that 10-minute period. The pharmacotherapy of buprenorphine naloxone. So buprenorphine is a synthetic partial mu opiate agonist. So what does that mean? It binds to the opiate receptor and it stimulates the receptor enough to alleviate opiate withdrawal and reduce cravings. And you can think of it as being really sticky to the opiate receptor, having a really high affinity to the receptor. So if there's other full opiate agonists like heroin or fentanyl on that receptor, and we give someone a big dose of buprenorphine, it's going to kind of punt off the full opiate and bind to the receptor. And we'll talk about that in a little bit, but that's kind of the mechanism by which precipitated withdrawal can occur, because you're going from a full opiate agonist to a partial opiate agonist. So we try to avoid that. In general, buprenorphine causes less euphoria, sedation, nausea, and respiratory depression than full opiate agonists. So it has this kind of inherent safety profile compared to full opiate agonists. The naloxone component in the buprenorphine naloxone tablet does not have good bioavailability when we give it sublingually. So when taken as prescribed, essentially the naloxone does nothing. The only reason it's in the tablet is to prevent diversion of the tablet. So if you think of if an individual has an opiate overdose and we give them Narcan, we typically would inject it either into a muscle, or you could give it intravenously, or you could give it intranasally. And so if someone crushed a buprenorphine naloxone tablet and injected it, the Narcan is bioavailable and they would Narcan themselves. So that's the only reason the naloxone component is in the tablet. This is just a refresher of kind of what an antagonist, partial agonist, and full agonist are. So if you look at the bottom of your screen, the antagonist, the example here would be naloxone or Narcan. Regardless of the dose of naloxone that you give, you're going to have no opiate effect. So it just sits on that opiate receptor and kind of blocks the receptor. Buprenorphine is a partial opiate agonist. So you can see that initially on that yellow line, you get an incremental opiate effect. And then you see this kind of plateauing or a ceiling effect. And I want you to think of that primarily as in terms of respiratory depression. So at a certain point, even with higher doses of buprenorphine, you don't really see respiratory depression. Whereas with full opiate agonists, so this on the side, it says methadone, but this could be methadone or fentanyl or hydromorphone. As the dose increases, you're going to get more and more opiate effect, and in particular for respiratory depression. So that threshold is going to be different depending on someone's tolerance, but there will be a certain dose above which you're going to suppress their drive to breathe. This is just a little cartoon to show the mechanism of how we kind of traditionally start people on buprenorphine naloxone. So traditionally, when we start someone, we give it to them when they're in withdrawal. And so I want you to picture a withdrawal state as a state where they have a number of opiate receptors in their brain. And so this blue icon in the middle of your screen is an opiate receptor. And then when we give them buprenorphine, it binds to that receptor. It's a partial agonist, so it provides kind of partial activation of that receptor. And that's enough to get them out of opiate withdrawal and help with cravings for opiates. And then what's neat with buprenorphine naloxone is if they use full opiate agonists on top. So as long as their buprenorphine is adequately dosed, the bup has a really high affinity to that opiate receptor. And so if they use fentanyl on top, it can't really bind. And so it kind of blunts euphoria. And it also provides really good overdose protection. So in terms of pharmacokinetic, the onset of action is quite quick. So generally within kind of 30 to 60 minutes. So once someone takes the medication, they're going to start to feel a benefit right away. And it has a long duration of action. So half-life is a bit variable, but on average is around 30 hours or so. The duration of action is dose dependent. So lower doses don't last as long, whereas doses above and beyond 8 milligrams last kind of at least 24 hours. And it's metabolized in the liver and then eliminated through the feces. Contraindications and side effects, so known hypersensitivity to buprenorphine or naloxone. On here it says severe respiratory or hepatic insufficiency, which is a contraindication, but I think it always needs to be a risk balance. So if I have a patient who's using 2 grams of fentanyl a day, I know that they're at a severely high risk of death from overdose, and they would benefit from OUD. And when I'm thinking of my 3 kind of primary oral OUD options, so methadone, SROM, or buprenorphine naloxone, because of the safety profile, buprenorphine naloxone is still going to be my first pick in those patients. So it's listed as a contraindication, but I think we need to weigh that risk against the potential risk of overdose death without OUD. Acute alcohol intoxication, I think we probably shouldn't start many medications when someone's acutely intoxicated. Decreased LOC, and then the potential side effects are really the same as any side effects from an opiate. So headache, pain, nausea, vomiting, hyperhidrosis, constipation, insomnia, and vasodilation. Who's eligible? So they have documentation of an opiate use disorder, and then providing informed consent that this is a long-term treatment that needs long-term follow-up, talking about potential side effects, and then specific risks around the induction method. So counseling around risk of precipitated withdrawal. And we'll talk more about that. So in your baseline assessment, I'm just going to run through this really quickly so that we can get to the rest of the talk, but you want to document confirmation of opiate use disorder using DSM-5 criteria, a urine drug screen at baseline documenting kind of opiate use. That said, there may be circumstances where either you're not able to get a urine drug screen, or in a situation, perhaps a person has been abstinent for several weeks and you're starting them on buprenorphine naloxone for relapse prevention. They may not have opiates in their system, and it would still be appropriate to start. A pregnancy test, a thorough substance use history, especially with kind of attention to detail around concurrent depressant use, so alcohol, benzos, or other sedatives, review of PharmaNet, labs at baseline as with all OAT. But again, if these labs aren't done, it shouldn't be a barrier to initiating OUD. There's really nothing on their initial blood work that would change my management in terms of how I'm going to dose their buprenorphine naloxone. And then just a documentation around the treatment plan and rationale for starting this type of OUD. So we have two kind of primary ways of starting people on buprenorphine naloxone. And this is a bit of a decision tool as to how you can decide. So if a patient presents and they're already in moderate withdrawal, so their COW score is greater than 12, and it's been at least 12 to 24 hours since their last use, it makes sense to go with a traditional induction for the most part. If they are able to tolerate kind of waiting longer and waiting until their COW score is 12 or higher, and it's been 12 to 24 hours since their last use, you could wait longer, then go with traditional induction. Or if they don't think they could wait that long, or they prefer a low dose induction, then you can choose a low dose induction. And so I'll walk you through how to do both types of inductions. So starting with a traditional induction, so we want people to have, again, like empty opiate receptors. So if you think of that kind of cartoon that I showed you earlier, you want their opiate receptors empty. So in general, the guidance is at least 12 hours since last short-acting opiate use. But I would say with fentanyl, it can be slow to be fully cleared. And so in general, with chronic fentanyl use, we're suggesting 24 hours since their last use, and then longer with methadone. We can do a traditional induction several ways. If someone presents to the clinic and they're already in withdrawal, we could give them an initial dose and then reassess them throughout the day. More commonly, we do what's called a home induction, where we would write them a prescription for 2 milligram tablets. They wait until they have adequate withdrawal at home and then start their induction. But there may be a role for both. Certainly, when we're starting people in the emerge, sometimes they present, they're already in withdrawal, and we could start them in the emerge and then make a plan for bridging them to an outpatient OUD clinic. So this is what the clinical opiate withdrawal scale looks like. It's essentially a way of scoring someone's opiate withdrawal, looking at a variety of parameters. So it's similar to a CWA for alcohol withdrawal, but it's specific to opiate withdrawal. And generally, prior to starting buprenorphine naloxone, we want their COW score to be 12 or higher. When we do a home induction, sorry, just to go back, the COWS is generally healthcare provider administered, whereas the subjective opiate withdrawal scale, or SOWS, is patient administered. So generally we want their SOWS score to be 17 or higher prior to taking that initial dose of buprenorphine naloxone. So they score themselves. Just a note around precipitated withdrawal. So there may be slightly higher risk of precipitated withdrawal using traditional inductions compared to the low dose inductions or micro inductions. And the reason why this occurs is if someone still has full opiate agonists in their system, and then we give them a pretty big dose of buprenorphine, it has a really high affinity to that opiate receptor. So it punts off the full opiate agonist and it binds to the receptor, but it's only a partial agonist. So it's that relative difference that results in people feeling worse instead of feeling better once they take the buprenorphine. So to avoid this, we counsel people to wait before taking their initial dose of buprenorphine naloxone until it's been at least 12, preferably 24 hours if they're using fentanyl, and their COWS score is at least 12, or if it's a home induction, their SOWS score is at least 17. And generally we start with a 2 milligram dose. And essentially when they start, you take 2 milligrams. If they feel totally normal after that and they have no ongoing withdrawal symptoms, it'd be a very rare case, but you can stop there. If they have ongoing withdrawal, they feel a little bit better, but they're still having cravings, ongoing withdrawal, then you go 2 to 4 milligrams kind of every hour to a max of, I'd say 12 to 16 milligrams. In Canada, on the product monograph, it says 12. Most providers go to 16 on day 1. And essentially for day 2, you're going to look at their cumulative dose throughout the day. So if they took 2 and then they took 5 more 2 milligram doses, they had a total of 12 milligrams. Then on day 2, you give them 12 milligrams in a single dose, and then they have PRNs of 2 milligrams up to a max of 24 milligrams. In the US, the daily maximum is 32 milligrams. So it's not uncommon for providers to push a dose up to 32 milligrams, particularly if they've gone to 24, but they're still having cravings or they're still using on top. So yeah, just day 3, continue to titrate by 2 milligrams at a time. And your ideal kind of stable dose is one where they can take their medication once a day. They're not having withdrawal symptoms, they're not having significant cravings, but they're also not sedated on the dose. And then generally we would follow them up kind of initially quite frequently to ensure they're stabilized, and then once a week, and then people may graduate to being kind of once a month or less frequent. So what happens if they precipitate? You have several options. One is to try to continue to give buprenorphine doses to try to overcome the precipitated withdrawal, so continue to push their dose up to 16 milligrams. Another option is to wait longer. So essentially you're just waiting for more of those full opiate agonists to clear out of their system, and then you try again several hours later. A third option is to stop the induction altogether and then strategize with the patient to come up with an alternative time where you'll try again, or discuss other OUD options, so switching to methadone or SROM as potential options. You can consider inpatient admission, so like admission to a detox unit, etc., if you anticipate it will be a challenging induction. And then I probably don't have much time left, so I'm going to speed through this. So traditional inductions have been widely used in BC, but And there is much more literature around traditional inductions. However, there is a risk of precipitated withdrawal. And so there's been increasing interest around low dose inductions or micro inductions because the patient's able to initiate it while they're still continuing to use other opiates. So they don't have to go through this period of withdrawal. And there's likely a lower risk of precipitated withdrawal. So here's a little table that shows kind of pros and cons of both approaches. With a traditional approach, you can titrate someone quickly, whereas with a low dose induction approach, it's going to take you longer to get to a therapeutic dose. But the risk of precipitated withdrawal is lower with a low dose approach compared to traditional. And with a low dose approach, you don't require that period of abstinence. So as I mentioned, the patient can continue to use prescribed or illicit opiates while going through a low dose induction. And essentially the premise is that you start with very low doses of buprenorphine, naloxone, and each day that dose gets incrementally larger, such that once you get to 12 to 16 milligrams, the person can abruptly stop all other opiates because their opiate receptors are essentially saturated with buprenorphine. There's a number of different low dose induction protocols, some that are more rapid, kind of in the 4 to 5 day range, and some that are more prolonged up to 10 days. Generally, we'll blister pack the entire low dose induction, so they don't have to go to the pharmacy each day for it. Here's just a sample prescription of what that would look like. And just a summary slide. So traditional inductions require a period of abstinence from opiates prior to initiating it. So generally 12 hours if they're using short-acting opiates, things like hydromorphone, morphine, oxycodone. With fentanyl, the general recommendation is at least 24 hours of abstinence. And then you want to see that their COWS score is at least 12. With long-acting opiates, slow-release oral morphine or methadone. With methadone in particular, you're going to want to wait several days prior to initiating buprenorphine, naloxone. And yeah, I think there's a whole other echo on switching between. So I may skip over a bit of that, but risk of precipitated withdrawal is likely a bit higher with traditional inductions, and there's a variety of options for management. So either continuing and trying to push through, delaying, so waiting several hours and then trying again, or stopping the induction altogether and exploring other forms of oral OUD. And then low dose inductions or micro inductions are associated with increased patient comfort, as they generally don't have to go through a period of abstinence and withdrawal, but does take a longer time to get to a therapeutic dose. Baseline urine drug screens are recommended, but are reasonable to forego if it's going to be a barrier to initiating OUD.